My name's Shoaib. For those of you who don't know who I am, I'm one of the co-founders of Bite Medicine. We have a few doctors and colleagues in the chat who will be there to take your answers. Azim, Zach, and Richard are around, so hopefully they can take your answers. Now, before getting started, we have our certificate scheme. So if you've attended 3 live webinars over the last 2 or 3 weeks and you filled out the feedback forms at the end, you should be receiving a certificate shortly, hopefully within the next few days. Okay, and I wanted to say thank you to everyone for attending. I know it's like the weather outside is amazing and you've chosen to come and watch me talk about status epilepticus, so I'm very honored. I hope you're finding these very useful. We've had people attending from all around the world, Malaysia, Australia, different bits of Europe. So we are very honored. Okay, let's hop into it. Status epilepticus. This is actually one of my favorite medical emergencies because it's a bit like anaphylaxis. You see the patient deteriorating in front of your very own eyes. And once you treat them, hopefully, not all the time, but hopefully they get better. So you see them get unwell and then you see them recover. So it's a nice emergency, but it can be very scary. And it's probably one of the most common emergencies that I've had to deal with as a doctor in the emergency department and on the wards. So today I want you guys to imagine you are the clinician in hospital. Okay, so you're the clinician working on a busy ward. This is a very common situation that I found myself in. So, you know, you haven't had a break for 8 hours. You just happen to sneak away to the toilet, but the emergency buzzer goes off. And there is a 62-year-old man who's having a tonic-clonic seizure. You have a nurse with you. You are the first clinician on the scene. So you're the only doctor or the physician's associate, whatever it might be. You're the first clinician on the scene. You have a nurse and you have a patient who's having a tonic-clonic seizure in front of you. This is a timer, okay? The nurse has quite rightly so started timing and it's been 57 seconds since the patient started seizing. She is also very kindly, she or he is also very kindly taking the observations. And what do we think? Are we worried or not worried? By these observations, okay, so you guys aren't worried. All right, fair enough. Yeah, I mean, you could argue either way. I mean, the observations are fine. He's having a seizure. It's no big deal at this point. But he is having a tonic-clonic seizure, so you know you still need to act quickly. But you're right, the observations aren't concerning. 57 seconds, the timer is important, so keep your eyes on that. Question 1. Okay, time is ticking. Which of the following is the best first step? Are you going to quickly sprint to the toilet, or are you going to treat him, or are you going to do nothing? Or none of the above? It's not quite the same as doing nothing. Sorry, for those of you who've never used this before, go to menti.com and type in the code 543152. That will give you access to answering our questions. You can do this on your phone or on your computer. So that's menti.com, put in the code, and you can access the questions. I'm looking at the chat. So does he have IV access? I'm not going to tell you. Would you take OBS from someone who's seizing? Yes. I'll wait for a few more of you to answer. Just to let you know, some of you have turned on your video accidentally, so just keep an eye out. Turn your video off so no one else can see you. Okay, let's have a look. Whoops. Why did that happen? Okay, so that's interesting. You have a man who's having a tonic-clonic seizure, and most of you have chosen to do nothing or none of the above. That's fine. We'll come back to that. I want you to answer the next question. How long must a seizure persist for it to be classified as status epilepticus? Okay, yeah. Answer in the on the Menti. I'll give you a few more seconds to do that. Okay. Hopefully fairly straightforward. Good. Okay, let's go back to the last question, because now we can think about, so 4% of you ran off to the toilet. That's bad, because now your patient's just there seizing and potentially could be dying, so don't, don't just run away. Why do we not treat the patient? Give them midazolam, diazepam, lorazepam, whatever it might be. Why are we not treating the patient? Yeah, so most seizures self-terminate within 5 minutes. So you don't need to jump into giving medications. You would just kind of, you wouldn't just watch him, but you would A, B, C, D, E manage him. We'll get onto that later. Obviously, airway is always the most important thing. You would start off with that. You wouldn't jump into giving medications. So none of the above is the correct answer. Okay, it's only been 57 seconds. Most seizures resolve within a few minutes, so you don't need to jump into doing anything. How long must the seizure persist for it to be status epilepticus? It's 5 minutes. So once you hit the 5-minute mark, that's when you start worrying, because if the patient is seizing for 5 minutes, the chances of them having a prolonged seizure is high. So that seizure needs termination. You need to do something. But if it's less than 5 minutes, you don't need to jump in and give anti-epileptics. 30 minutes is the old definition. That's wrong. So I know a lot of you might have read that in certain textbooks or research papers. 30 minutes is the old definition of status epilepticus. Imagine if you didn't do anything for 30 minutes and the patient's just there seizing, they would have irreversible brain damage probably. So NICE and all the current definitions of status epilepticus, so there's one called the International League of Epilepsy, they all define it as 5 minutes, and that's what you need to know for your exam. There's a very particular reason we've chosen 5 minutes, and I'll get onto that in a second. So good, we've done those first 2 questions. This is the key information highlighted in yellow. He's having a tonic-clonic seizure, and it's been 57 seconds. Time is crucial. Anytime someone is having a seizure, the first thing you do is you get your stopwatch out, start timing, whilst obviously sorting out his airway, because the time is going to dictate how you manage the patient. Everything else is kind of irrelevant in this case. I mean, you need to go to the toilet. That's sad, you know, we often find ourselves in this situation where you just don't have time, but you need to sort out the patient. That's your priority. The observations are largely unremarkable, I agree. I'm not particularly worried. You would continuously monitor, so you'd regularly monitor the patient's observations whilst they're having a seizure for various reasons, which we will get into. So I hope that was fairly straightforward. What is status epilepticus? So it's a seizure lasting greater than 5 minutes, or if you have 2 or more seizures and you do not regain consciousness in between. Both of those are classified as status epilepticus according to NICE guidance. Status can be further divided into convulsive versus non-convulsive. And this is a very important distinction, because the way you manage convulsive status epilepticus is different from the way you manage non-convulsive status epilepticus. And I will go into that distinction in a few slides. The take-home point from this slide is the definition of status, and convulsive is the one where we need to act urgently. Non-convulsive, you've got some time. You don't need to jump in straight away. Okay. So why do we worry about status epilepticus? The mortality can be high, up to 20% in adults and 15% in children. So it is the most common neurological emergency in children. I've seen it a few times in children. It can be very sad. They end up needing intubation and going to ITU. And if you think about this, 15% means 1 in every 7 or 8 children with status will die. So that's why we get worried about status epilepticus. Good. The longer the seizure lasts, the poorer the prognosis. And the reason for choosing 5 minutes is that once you cross that 5-minute threshold, your seizure is likely to persist and it probably won't self-terminate, which is why you need to act quickly. Good. Good. I hope that was all straightforward. There are some doctors in the chat if you have any further questions. Causes. So what causes status epilepticus? There are many. The most common in adults is epilepsy. And the most common cause in children are febrile convulsions. I think epilepsy is fairly straightforward to understand why that would cause status epilepticus. If someone is not compliant with their medications, if they just have really poorly controlled epilepsy and they have a seizure, they're at risk of crossing that 5-minute threshold into status epilepticus, okay? Febrile convulsions, most common cause in children. Some of you might not know what a febrile convulsion is. A child who's typically less than 5 years old, when they get a temperature, any cause of temperature, usually a viral infection, they are at risk of having a seizure. Children have a low seizure threshold compared to adults. Once they spike a temperature, they are at risk of having a seizure. If they have a seizure and it persists longer than 5 minutes, as we discussed, that would be classed as status epilepticus. So febrile convulsions are the most common cause in children. And every time I've seen status epilepticus in a child, it has been because of a temperature. So that's important to note. The other causes are slightly less common. So infections can cause metabolic disturbances, which can cause seizures. Stroke, you can get edema and infarction, and that structural change can initiate a seizure. Again, hemorrhage, just purely from the inflammatory response and the structural changes, you can get a seizure. Alcohol can cause seizures in many different ways, most commonly due to alcohol withdrawal. So if someone has been a chronic alcohol abuser and then they stop drinking alcohol all of a sudden, they are at risk of developing seizures and therefore at risk of developing status epilepticus. Recreational drug use, can you guys name some drugs which cause seizures? Any drugs? MDMA, yeah, I think so. Quinolones, that's pretty niche. Yeah, ciprofloxacin does reduce your seizure threshold. So I'm looking at cocaine, yeah? People who abuse cocaine, benzo withdrawal, tricyclic antidepressants, aspirin overdose, all of these things can cause seizures. So the point is, don't abuse alcohol, don't abuse drugs, because you don't want to be that guy who ends up with status epilepticus. Electrolyte imbalances, particularly hyponatremia and hypocalcemia, can cause status. So some of you might be asking, and I saw in the chat, what's the difference between epilepsy and status epilepticus? Status epilepticus is a seizure which lasts longer than 5 minutes, can be caused by anything, okay? It can be caused by any of these causes. Epilepsy is a specific cause of status epilepticus. So I hope that's clear. So we had the definition of status epilepticus, and remember I said we have convulsive and non-convulsive. So why do we bother making this distinction? What's the point? I know I said we treat them differently, but why split them up? Does anyone have any ideas as to why status is categorized? Different treatment, kind of, like it's more not, yeah, so it's to do with the urgency and the risks. With convulsive status epilepticus, the risk of mortality and the risk of irreversible brain damage is higher than non-convulsive status epilepticus. And we will get into that on the pathophysiology slides. But that is the reason why we split them. So what is convulsive status epilepticus? It's referring to a tonic-clonic seizure. Okay, tonic-clonic seizure means all 4 of your limbs get stiff, and then they jerk, and then they get stiff, and then they start jerking again. It's the sort of seizure you see in the movies where, you know, the patient drops to the ground, start foaming at the mouth, all limbs twitching. That is your typical tonic-clonic seizure. I have a video of it coming up, so don't worry if you can't quite imagine it. Non-convulsive, you don't have those convulsions. Absent seizure, where you just stare out into space blankly. You don't have the motor twitches, and that is most commonly seen in children. So if you have an absent seizure where you're just staring out into space for longer than 5 minutes, that is classed as non-convulsive status epilepticus. Focal seizures are typically classed under non-convulsive. And again, these are 3 different types of seizures. You kind of need to understand how we classify seizures in order to better understand this slide. And that is why I have prepared the next slide. So yeah, basically convulsive seizures are the ones we worry about. How do we classify seizures? What are the 2 types of seizures? We classify seizures based on where they're located. So generalized and focal, good. So generalized, focal. Let's go into generalized first. I don't really want to go into the nitty-gritty of seizure classification because it gets a bit confusing. And so I've kind of simplified it here, and this is what you need to know for your exams. And hopefully you'll remember everything that you see on this slide. A seizure can be split up into generalized, which means both hemispheres are involved. So remember, a seizure is overactivity of neurons in the brain. If you have activity on both sides of the brain, that's called a generalized seizure. A generalized seizure can further be split up into those that cause motor symptoms and those which cause non-motor symptoms. Can you list some motor generalized seizures for me? Tonic-clonic, that's the one I wanted to hear. There's a bunch of others, but tonic-clonic, that is the main type of generalized seizure. And that is the one that is convulsive status epilepticus. So when we talk about convulsive status epilepticus, we're talking about a seizure which is generalized, therefore involving both hemispheres, and is a motor form of generalized seizures, specifically tonic-clonic seizures. Non-motor generalized seizures are absent seizures where you stare out into space blankly and you do not respond. You're unaware of what's going on around you, okay? In generalized seizures, you tend to lose consciousness or not be aware of what's going on around you. Okay, so fine, we've done generalized. So what is focal? Focal is where you only have activation of one hemisphere. So it's on one side of the brain, not on both sides of the brain. These can then be split up into whether or not the patient is aware of what's going on or not aware of what's going on. So you can have focal impaired awareness or focal retained awareness seizures. In the old classification, which you may come across in the Oxford Handbook and other textbooks, these were called simple partial and complex partial seizures. That classification has now gone out the window. We don't use that anymore. Previously, focal was referred to as partial, retention of awareness was referred to as simple, loss of awareness was referred to as complex. That's all no longer used in old terminology. The point is, focal seizures on one side of the hemisphere, you can either have awareness where you're aware of what's going on around you, or you lose awareness and you have no idea what's going on. I think the terms are pretty straightforward. That's why they changed the names. Complex partial and simple partial didn't really mean much, but retained awareness and impaired awareness makes a lot more sense to me. So fine, you know your patient's having a focal seizure, you know whether or not they have awareness. The next way you categorize it is whether or not the patient has motor symptoms. So do they have motor symptoms or non-motor symptoms? And that's basically the classification of seizures. The point I wanted you to take away is that convulsive status epilepticus is a motor generalized seizure. I'm not going to go into this. This is just more for your reference because I know some of you might be interested. The different types of generalized seizures and the different types of focal seizures based on whether or not they have motor or non-motor symptoms. So tonic-clonic, that's the one I wanted you guys to focus on. That's the one we are worried about. You can come back and look at this slide later. This is taken directly from the International League of Epilepsy classification, so it's the most up-to-date. Okay, going back to this, hopefully that explains the different categorizations of status epilepticus. Tonic-clonic is a generalized seizure with motor involvement. Absence seizures are generalized with non-motor involvement. Focal seizures are focal seizures with involvement of only one hemisphere. Okay, that is a bit simplified, but it's enough. That's all you need to know for your exams, pretty much. Fine, so what is going on in a seizure? Put it simply, there's an imbalance between excitation and inhibition in the brain. The balance shifts towards excitation. You're having too much glutamate and all of those excitatory neurotransmitters being released, and that triggers a seizure. If the seizure fails to terminate after 5 minutes, then you go into status epilepticus. Why some patients go into status and some don't, we don't really understand. The point is, if you're reaching the 30-minute mark of convulsive status epilepticus, that's when you're going to start to get cerebral damage. The most sensitive area in the brain to this is the hippocampus and the temporal lobe. So after 30 minutes of convulsive status, patients tend to develop temporal lobe and hippocampal irreversible damage. That's why we act at 5 minutes before you hit the 30-minute mark, essentially. So you want to save the brain, you want to save the neuronal tissue, and ideally save the patient. Why does this brain damage occur? So that's what this flow chart here is showing. Status epilepticus, why do we get a raised lactate? What's going on there? Patients often have really high lactates in after seizures, sorry. The lactate can reach sort of 17, 18. Yeah, so imagine you're having all 4 of your limbs contracting. You're having lots of energy expenditure in your brain from all the neuronal activation. All of that energy expenditure is going to shift you into a state of anaerobic respiration, and your lactate levels are going to go through the roof. High lactate levels for a long period of time can cause brain damage. So that's one of the reasons why you get neuronal damage. Similarly, hypoglycemia, if you're having so much energy expenditure, you're using tons of glucose, you're going to drop your glucose levels and therefore deplete your energy stores, and that can cause neuronal damage. Hypothermia from all the muscle contractions can cause brain damage. It's thought that glutamate, so all of this excitatory transmitter release, glutamate is the excitatory transmitter in the brain. If you have that building up, that will cause neuronal damage, okay? So prolonged exposure to high levels of glutamate cause brain damage. And finally, hypoxia. Similarly, you're using all the energy, your oxygen consumption is high. Patients may lose their airway and struggle to breathe. You become hypoxic. Of course, if you're not supplying oxygen to the brain, then you're going to get neuronal damage. Good. I hope that's all fairly straightforward. Let's move on. I mean, the clinical features, this is describing a tonic-clonic seizure. We've seen it, limb jerking, limb stiffness. You can get tongue biting. So patients from contraction of their jaw muscles can bite their tongues. Even worse, their tongues can sort of flop back into their airway, and you can get airway obstruction. They often have urinary incontinence because they lose control of their bladder during the seizure. So patients will urinate themselves. Of course, they lose consciousness. And as I mentioned, in the post-ictal phase, they're confused with a reduced GCS. Okay, good. So investigations, how are we going to investigate someone who's having a seizure, who's having status epilepticus? Of course, some of these investigations are more urgent than others, and we will go through it. you would do an ECG if you're able to. It might be difficult to stick on the leads if the patient's having a seizure. At the very least, you could probably get a 3-lead ECG, and that's to check for any arrhythmias. Arrhythmias can cause seizures, okay? Not only can arrhythmias cause seizures, but seizures can cause arrhythmias. How does arrhythmia cause seizure? Well, if you're having an arrhythmia, you sometimes might drop your cardiac output and reduce cerebral perfusion. Reduced cerebral perfusion can cause a seizure. It's a rarer cause of a seizure, but something you should look out for. Always glucose. We measure glucose for every emergency. Remember, don't ever forget glucose. Hypoglycemia can cause a seizure and can cause status epilepticus. You must get bloods off of the patient whilst they're having a seizure. So when the patient is seizing, you have to take observations, you have to get IV access, and you have to take bloods. It might be difficult because the patient's arms and things are twitching, but what you do is you hold the patient down. So a couple of you will hold the patient down, hold the arm still, and you will take the bloods. Venous blood gas, you can do an arterial as well if you're concerned about oxygenation, but that's to check for the lactate levels. Remember, lactate is elevated usually after or during a tonic-clonic seizure. It wouldn't be particularly elevated in someone who's not having motor symptoms. So, for example, in an absence seizure, you wouldn't expect your lactate really to be raised. You do a standard set of bloods, so check the inflammatory markers. Is this whole thing being driven by infection? Check the electrolytes, because remember, hyponatremia and hypocalcemia can cause seizures. If the patient is a known epileptic, check anti-epileptic drug levels. They may be subtherapeutic, i.e. the drug level in their blood is too low, and that's why they are having seizures. So check anti-epileptic drug levels. Once the patient has stopped seizing, you might consider a CT head. Could the seizure have been triggered by some problem in the brain, like a bleed or a weird congenital structural lesion? Special tests, of course, I mean, you're not going to do an LP whilst the patient is having a seizure, but if you're concerned about something like meningitis, which may have triggered the seizure, then do a lumbar puncture. Ultimately, patients who have seizures will need some form of EEG monitoring, and that's to look at the brain activity. I mean, not everyone with a seizure ends up having an EEG, but if a patient has had an episode of status epilepticus where they've had a seizure for longer than 5 minutes, it's something you definitely consider. So I hope there's no surprises there. They're all fairly straightforward investigations. Okay, we're back to our guy. So you haven't gone to the toilet. You have decided to save the day and stay with your patient. We're still at the 57-second mark. Time has not moved. Okay, so same state of affair, first clinician on the scene. Observations are exactly the same as before. Let's move over to the question. Which of the following should be performed first? Okay. Position the patient prone. Prone means on your belly, so lying them on their belly. Intubate the patient, sit the patient up, roll the patient on the side, or commence high flow oxygen. So there's a few options here. And what I'd say for this question is, remember, what are you trying to manage first? What's the thing that's going to kill the patient first? We're still at the 57-second mark. So let's have a look at what you guys think. Yeah, good. So airway is priority. If the patient loses their airway, you can put them on all the oxygen that you want, but they're going to die because that oxygen is not reaching the lungs. There's a reason we always start off with airway, followed by breathing, followed by circulation. Do it in that order because that's what will save the patient's life. So the first thing you do when you see the patient having a seizure is you roll them onto their side and you put their head facing down. That's to prevent their tongue from collapsing back into their airway. And you would then start high flow oxygen after that and probably put in an airway adjunct, but we'll go into that in a bit. I mean, you wouldn't put the patient on their belly. You wouldn't intubate the patient at this point. You would do that maybe later on, as we will see. Sit the patient up. I mean, it's pretty difficult to sit someone up if they're having a tonic-clonic seizure. You just put them on their side. It's the easiest and quickest thing to do. And that will temporarily help protect the airway and prevent aspiration as well. Okay. So management. The first thing you do is you walk in, you've seen the patient having a seizure. Thankfully, the nurse has already started timing. So that's step one. You start timing, figure out, you want to keep a track of how long this patient has been having a seizure for. Position them, so you position them on their side, typically with their head facing down. And again, that's to prevent aspiration. If they're having any, if they sound like they're having saliva collecting in the back of their throat, you can suction that saliva out. Then you would stick in an airway adjunct at this point because the patient is at high risk of losing their airway. So as a junior doctor or a physician associate, the first airway adjunct that you would use would either be an oropharyngeal or a nasopharyngeal. So the top one is an oropharyngeal, also called a Goodell. The bottom one is a nasopharyngeal, and it's just called nasopharyngeal, yeah. This one goes in the mouth and this one goes in the nose, okay? And you can choose either or. It doesn't particularly matter, just whichever one you feel more comfortable with inserting. The only thing to note is in patients who have some degree of consciousness, so I'm not talking about so much status epilepticus, but in other emergency situations where the patient is still conscious but deteriorating, if you stick in an oropharyngeal airway, they won't tolerate it because you're sticking something down their throat. They're going to start gagging. In which case, you're better off sticking in a nasopharyngeal, which goes into the nose. And patients who are aware and awake tolerate it a lot better. But I mean, in status epilepticus, it's not a huge deal because the patient's knocked out anyway, so you can put either one in. Breathing. So remember, we've done airway. Okay, we've sorted that out. We've put the patient on the side. We've stuck in an airway adjunct. That's great. Next thing is breathing. So for those of you who are here for my anaphylaxis lecture, we went through the rule of 5. This is the best way to work through breathing and circulation. Observations: patient's respirate was 15, saturation's 95%. Let's imagine they're not cyanosed. Their central examination is normal. The trachea is central. They are breathing okay. They're getting air into both lungs, so that's good. The way you'd ascertain that is by obviously listening to their lungs. You would order for an urgent chest x-ray. Okay, I'd say it's not the most, I mean, you wouldn't do it as the patient is having a seizure, obviously, but it's something which needs to be done at least, once the patient has stopped seizing, because these patients are at risk of aspirating and then having an aspiration pneumonia. So at some point, you do need to conduct a chest x-ray. Management, so once you've sorted out the airway, in status epilepticus, you always put them on high flow oxygen, okay? It's not, it doesn't particularly matter what the oxygen saturations are in this instance because you want to increase oxygenation to the brain as much as possible. So put them on high flow oxygen, sort out their airway as we've already done, and then we can move on. Circulation is always next. Again, the rule of 5. Go back to the anaphylaxis lectures if you want to go through this in a bit more detail. His heart rate and blood pressure, they were pretty all right. Let's imagine his capillary refill time, that's what CRT stands for, is 2 seconds, which is normal. His pulse is fine. He's well perfused. So we are not concerned so much about his circulation. He's perfusing his organs and his peripheral tissues okay. You listen to his heart and there's normal heart sounds. As part of circulation, you gain IV access and you take bloods. So remember, the patient's having a seizure, it doesn't matter, you still need to gain IV access. You hold the patient down, so you isolate one of the limbs, for example, like the arm, and you stick in a cannula and take bloods. That is absolutely essential because that's how you're going to give your medication. Management, commence anti-epileptic drugs if it goes beyond the 5-minute mark, as we've discussed. Disability, don't ever forget glucose, okay? Because that's a cause of status epilepticus. If the patient is hypoglycemic, you could correct that hypoglycemia and save the patient. So never forget glucose. Regularly check the patient's GCS. I mean, again, I appreciate that's a bit difficult to do if they're having a seizure. It's more something you do once they've stopped seizing. Expose the patient, try and figure out why is this patient having a seizure. Is there some underlying cause? Have they sustained trauma to the head, for example, and have they got a massive hematoma at the back of their head that you've missed? Again, a bit difficult to do if they're having a seizure, but something to be aware of. That's why it's kind of lower down on the list of things. ABC is the most important. Okay, question 4. We've hit the 5-minute, 7-second mark. You've crossed that 5-minute threshold. As the smart clinicians that you are and the very capable clinicians that you are, you've all put in an oropharyngeal airway. Your patient is tolerating it. You've stuck on high flow oxygen and you've put in a cannula because you're all very fast and competent. The nurse is helping you out. The patient has now crossed the threshold. They are in status epilepticus. No one has come to your help and you are there alone, okay? So you're there to save the day. Everyone's looking at you, all eyes are on you. These are the observations. Heart rate 95, blood pressure still the same, respirate's fine. You've pushed the saturations up to 100% because you put them on high flow oxygen, and their temperature is still the same as what it was before. Okay, so the observations aren't particularly concerning. Okay, so let's go over to the question. So what is your first line management? The nurse turns to you and says, "Doctor, what are we going to do next?" Buccal midazolam, rectal diazepam, IV lorazepam, IV valproate, or oral diazepam. Lots of PAMs and AMs. Which are you going to go for? Okay. Oh, good. Why does that happen? IV lorazepam. Interesting selection. 63% of you have gone for that. Okay, let's work through these. Why would you not give buccal or rectal midazolam? Isn't that the quickest thing to give? Is there IV access? I don't know, you tell me. You're the one who should have cannulated the patient. Yeah, so remember the case scenario said he's got IV access. If you've got IV access, you don't mess around, you just get it straight in, but you give the medication IV. If there wasn't IV access, then you would consider buccal or rectal buccal midazolam or rectal diazepam. IV valproate is not used for status epilepticus. That is not licensed for the use in status epilepticus. You need something which is going to terminate the seizure quickly. Benzodiazepines are very good at terminating seizures quickly. Oral diazepam, I mean, how are you going to give something orally if the patient is in status epilepticus? They don't have an airway, they can't swallow. If you give them something orally, they're at risk of aspiration. So the answer is IV lorazepam. Just to clarify, what exactly are all of these things? Midazolam, diazepam, and lorazepam are all benzodiazepines, which potentiate the GABA inhibitory receptor in the brain. By causing inhibition, they will terminate the seizure. We will go into when you give buccal versus rectal versus IV in a bit, but most of you touched upon it. I mean, if they've got IV access, just stick in some IV medication. Okay, fine. So 5 minutes, 7 seconds, you've given some IV lorazepam. Okay, it's 15.5 minutes now. The patient is continuing to fit. Someone has finally turned up to help you. The anaesthetist has appeared and asks you what you'd like to do next. You're not going to stare at him or her blankly. You're going to come up with a good solution. So let's look at the observations. The heart rate is 105. So he's becoming a bit more tachycardic. He's dropping his blood pressure now. The breathing stuff's kind of okay, isn't it? Rest rate 19, saturating 96% on high flow oxygen. The temperature is starting to go up now. The patient is becoming hyperthermic from all of their muscle activity. It's generating lots of heat and they're becoming hyperthermic. 15.5 minutes have elapsed. What are you going to do? You need to save this patient. Okay, just give me a second. Excellent. What is the most appropriate next step in management? IV lorazepam, IV phenobarbital, IV diazepam, rapid sequence induction. So that's sedation where the anesthetist will intubate and knock the patient out, or paraldehyde. So it's been 15.5 minutes. I'm just reading the chat. Some of you asking, what's buccal? Buccal is where you put a bit of liquid solution into between the tongue and the cheek, basically, and it's absorbed like that. It's different from giving an oral tablet. So all eyes are on you to save this patient. Let's see what you're going to choose. Are you going to save the patient, or is the patient going to die? 35% of you have gone for IV phenobarbital. Okay. I mean, you're on the right lines. You're going to give something IV on you. So it's either going to be IV lorazepam, IV phenobarbital, or IV diazepam. You're not going to quite yet jump into intubating the patient. Paraldehyde's probably, or might be, something you've never heard of before. It's typically used in children in status epilepticus. It's not used in adults. So you'd give another dose of IV lorazepam. It's 2 doses of lorazepam, and then you consider other medications. You always give 2, well, you don't always, but you can give 2 doses of benzodiazepines, okay, before you then need to escalate to the next anti-epileptic drug. So give IV lorazepam, wait about 10 minutes or so. If the seizure has not terminated, give another dose of lorazepam. If the seizure then has still not terminated, then you're in a bit of trouble and you need help. So how are we going to manage convulsive status epilepticus? So early on, you turn up to the scene. First line, IV lorazepam, 4 milligrams. You can repeat it within 10 minutes. If the patient does not have IV access, so for example, you just can't get a cannula in, or the patient is in an ambulance, for example, they haven't yet arrived at hospital, then you can give rectal diazepam or buccal midazolam. So rectal diazepam is a solution which goes into the rectum. Buccal midazolam is a solution which goes into the mouth. They're both absorbed and then hopefully terminate the seizure. They are actually quite effective. And particularly, we tend to go for these in children because sometimes in children, it can be very hard to get access, particularly if they're seizing. But the point is, we had IV access in our patient. So first line, IV lorazepam. If that fails, give another dose of IV lorazepam. Know the dose, 4 milligrams. If you've got an old, frail lady or man, don't give them the full whack. You can give them, say, 2 milligrams or something. But 4 milligrams if you've got a reasonable sized adult. Okay, 24 minutes, 7 seconds. The patient is continuing to fit. The heart rate is going up and the blood pressure is dropping. Your saturations are dropping despite being on 100% oxygen, sorry, high flow oxygen. The temperature is rising and you are panicking. You're starting to sweat. What are you going to do next? So it's 24 minutes now. You've given 2 doses of lorazepam. The patient is still fitting and the anaesthetist is not doing anything. What are you going to do? I'm just looking through some of your questions on the chat. So someone's asked a good question here. Is it still maximum of 2 doses of IV lorazepam, even after rectal buccal diazepam? That's a very good question. I'll come on to that in the PowerPoint slide. Yeah, good. So IV phenytoin, okay? If you, after 2 doses of benzodiazepines, the patient is still fitting, give them phenytoin. You load them on phenytoin. Phenobarbital is an alternative, but we typically go for phenytoin. You do not give a 3rd dose of lorazepam because they will overdose and you will cause unwanted effects like respiratory depression. You still don't intubate them just yet. Glucose, you would give them if they were hypoglycemic, but we have no evidence of that. Okay. So we've gone over the early management. Someone asked, so you give a maximum of 2 doses of benzos. So if you've given a dose of rectal diazepam, they can only then have 1 dose of IV lorazepam. If they've had 1 dose of buccal midazolam, they can only have 1 dose of IV lorazepam. You can only have 2 doses of benzodiazepines. You don't give them a 3rd dose, okay? So it doesn't matter what combination it is. If it's 2 doses of IV lorazepam, if it's 1 dose of rectal diazepam and 1 dose of IV lorazepam, it doesn't really matter. They can only have 2 doses. Fine, so that's early. Once you have established status, literature defines this as various differing time points, but some say 10 minutes, some say over 30 minutes. The point is, if the patient's not improving after you've given benzodiazepines, you call the anaesthetist and ask them to come down urgently. You start the patient on phenytoin. Okay, this is more commonly used. You can also use phenobarbital and you can use them together. So you can give phenytoin and phenobarbital together. So typically 2 doses of benzos, then phenytoin. Now, this is where it becomes dangerous. I mean, we're entering unwanted territory here. The patient is still fitting despite giving phenytoin. That's when you anesthetize the patient. You ask, well, the anesthetist will turn up and he'll intubate the patient and knock the patient out with one of these drugs, propofol, midazolam, or thiopental. So knocks the patient out, takes them to ICU, and I mean, if the patient is at this stage, that's not good news. They may well have sustained irreversible brain injury. Their risk of mortality is increasing. So I've got a little stat here for you. If seizures continue despite 2 anti-epileptic medications, the mortality rate is as high as sort of 38 to 40%. So if you're given 2 anti-epileptic agents and they're still fitting, the mortality chances of death are 4 in 10. Okay, not good. The patient has stopped fitting and you have saved the day. So 29 minutes, 33 seconds, okay? Well done. His eyes do not open when you shout his name. So this is now the post-ictal phase. The ictal phase is the seizure. The post-ictal phase is after the seizure. His eyes are not opening when you shout his name. When you pinch his eyebrow, he opens his eyes and moves away. His speech is confused. Observations are starting to improve. I'm going to ask you a question on this patient's GCS, if you give me a second. So here it is. His eyes do not open when you shout his name. Pinch his eyebrow, he opens his eyes and moves away. His speech is confused. What is his GCS? So you need to know this. You need to know how to work out Glasgow coma score. Very commonly used in emergency situations. It's as part of the ABCDE assessment. In disability, you calculate usually a patient's GCS. There are other scores that you can use, but GCS is very commonly used. Okay, so we're coming to the end. Just in case you guys are wondering, I know that some of you might have to shoot off, so we've got a couple more slides before we finish up. Okay, so the answer is 10. Good, for the 32% of you that got that. The easiest way for me to explain it is literally just to show you how we actually measure GCS. A big table with lots of numbers. GCS is split up into eyes, verbal, and motor communication, motor response. So you check what is the patient doing with their eyes. This patient only opened their eyes to pain. So when you squeezed their eyebrow, the supraorbital squeeze, only then did he open his eyes, okay? So he scores a 2 for eyes. His speech was confused, so he scores a 4. And remember, when we did the supraorbital squeeze, he moved away, so he withdraws from pain, so he scores 4. So 4 plus 4 plus 2 makes 10. So his GCS score is 10. The maximum score is 15. So currently, you and I have a GCS of 15, hopefully. If it's not 15, then something is very wrong. And you break it down into eyes, verbal, and motor. The way you would document this is the patient has a GCS of E2, V4, M4. Okay, that's how you might see it written out when you're documenting in clinical practice. I hope that makes sense. Just go through this table in your own time. Sadly, you just need to learn it. I always struggle to remember it, to be honest. I don't have any neat tips or tricks to give you about how to learn this. If anyone does have any good mnemonics and things, just please post it in the chat. Okay, so fine, we've done adults. I want to quickly touch on how we manage status epilepticus in children. It's pretty much exactly the same. Some of you might be wondering, where are these management guidelines from? They're from NICE. So this is all NICE guidance on how to manage status epilepticus. If you're interested, we have a section on status epilepticus on our online textbook, which goes through all of this quite neatly. So do check it out if you get a chance. The only difference is the time frames are slightly different, but the point is you start off with a benzodiazepine. You can give 2 doses of benzos. It doesn't matter in what combination, whether, again, if it's 1 dose of buccal midazolam or 1 dose of IV lorazepam or 2 doses of IV lorazepam. You can give 2 doses of benzodiazepines. You then escalate to phenytoin or phenobarbital as you did before. If it's continuing for 45 minutes, knock the patient out with thiopental and take them to intensive care. This is scary. I've seen, I've been involved in cases and heard of cases of children going into status epilepticus whilst I was working on a pediatric ward. And you know, it's very distressing for parents to see their child having a seizure. And it can be quite manic with having, you know, parents there, everyone worrying. So it's something that you need to be aware of and familiarize yourself with the algorithm. Okay, so we've done convulsive status epilepticus. There's literally 2 or 3 slides left now. Non-convulsive status epilepticus. So this is where you don't have the tonic-clonic seizure, but you have, say, an absence seizure. Treatment is not as urgent because the risk of damage to the brain is lower. You're having less activation of the brain. You're having less activation of the tissues. If you go back to the pathophysiology slide, that little flow chart that I showed, you're going to have, you know, the lactate's not going to rise as much, the hypoxia, etc., is not going to kick in as quickly. So you've got a bit of time if you've got non-convulsive status epilepticus. There isn't a set guideline on how to manage this, but what NICE says is that if the patient is aware and basically they're able to swallow, you can give them an oral anti-epileptic. If they don't have awareness, you can manage them as you do for convulsive status epilepticus, give them IV lorazepam, etc. You rarely need to anesthetize these patients. and the outcomes are much better. You don't really need to know this for your exam. You need to know how to manage convulsive status epilepticus for your exams. This is niche, and I just thought for completeness, I would put it in. Complications, so acute or chronic. Hypothermia is obvious. I mean, if they're having muscle contractions for half an hour, you're going to raise your temperature. All of these other complications like pulmonary edema, cardiac arrhythmia, and cardiovascular collapse are less well understood. Pulmonary edema is thought to be due to autonomic activation. For some reason, when you get a seizure, you have autonomic activation, and that causes edema in the lungs. Similarly, if you have autonomic activation, that can cause cardiac arrhythmias and cardiovascular collapse. So imagine if you're having loads of vagal stimulation of your heart and of your blood vessels, etc. That's going to interfere with your cardiovascular system. Chronic, these patients can have irreversible brain damage and get neurological deficits. And status epilepticus can sometimes be the first presentation of epilepsy. So a patient may never have had a seizure before, comes in, has status epilepticus, and then has seizures for the rest of their life, and is diagnosed with epilepsy as a result. Okay. Top decile questions. So we're coming to the end now. We've got 2 top decile questions for you. It's a little quiz. Sorry. Okay, yeah, so go to menti.com, put in your little username and things, and we will get started. So the quicker you answer, the more points you get. So you need to be quick. Just like managing status epilepticus, you don't have time to mess around, okay? You need to be quick when answering these questions. Answer fast to get more points. So me and the team were quite disappointed that you guys found our top decile questions easy last week. So we decided to make them harder. So you only have yourselves to blame if these questions are too hard, because you're all too smart. Okay, so we have a healthy young man. Refractory seizures, no identifiable cause. What is going on? Just to clarify, you wouldn't need to know the answer to these 2 questions for your exams. They're just for, you know, a bit of fun. Can't believe it. 60, yeah, most of you got it right. We still need to make them harder. This is very disappointing, actually. I'm glad you guys got it right, though, so well done. But we need to go back and make the questions harder. So why does this happen? I will go into that. I've got a slide on it which explains why autoimmune encephalitis is the likely diagnosis. But basically, in a healthy person who's developing refractory seizures, prolonged seizures with no identifiable cause, the most likely cause is going to be autoimmune. Okay. Leptomeningeal carcinomatosis and EBV-induced neurotoxicity are 2 other causes. They can also cause refractory seizures, much less common, and you probably would have picked up the cancer on CT imaging. Here it says no readily identifiable cause. You would have done a CT by this point, so that's why this isn't correct. EBV-induced neurotoxicity is very rare. These 2 things don't really cause refractory seizures. Don't worry if you didn't get that. That's all written on the slide. So, oh no, I think we skipped one of the questions. Okay, Dwight Schrute. It's actually one of my favorite characters. Well done, Mary. Sorry, we missed one of the questions. I don't know why that happened, but nevertheless, well done, Mary. There's no prize, but I'm very impressed that you answered so quickly. I'm sorry that other top decile question didn't turn up. That was quite a nice one as well. So this is what the other question was on, and the correct answer was going to be Rasmussen syndrome. I'm not really going to go into it now, but you can look at this slide in your own time. We had a few nice things on there, like exploding head syndrome and Alice in Wonderland syndrome. Would have been a nice question, but you know, some things just aren't meant to be. This slide explains the question that we just did on autoimmune encephalitis. But the point is, if you have someone with prolonged refractory seizures with no identifiable cause, they probably got autoimmune encephalitis. All the other things were either less common or do not cause refractory seizures. Okay, sorry, I've run over by about 7 minutes. Stick around for a bit for the feedback form and I'll take some of your questions. Status epilepticus is a seizure which lasts longer than 5 minutes or the patient does not regain consciousness. Convulsive status is what we are concerned about. Always protect the airway. You're going to be on the ward soon. Protect the airway at all costs. That's your priority. Then the breathing, then the circulation, and everything else will follow. Start anti-epileptics after 5 minutes with benzodiazepines as first line. Associated with a high mortality, that's why we worry about it. Some references for you. There's the QR code for the feedback form. I'm going to stick around to take some of your questions. Feel free to head off whenever you like. A few announcements. If you want to get involved, we are so grateful that so many students have come to us and our representatives are really helping out writing content for us. Very grateful because Bite Medicine will not exist without you guys. Email us at opportunities@bitemedicine.com if you feel like you've got something to offer. We love to get students involved. Join our Facebook group, Bite Medicine for Students. Post your questions in there. We will answer your questions. Like us, follow us on Instagram. What else? YouTube, subscribe to us on YouTube. And yeah, just say hi, really.